The air we breathe brings the world within, linking us with everything. Our lungs can't bear this constant weight. Why is respiratory health taken for granted? Why millions of people across the globe are suffering from chronic respiratory diseases? These fragile organs are vulnerable to asthma, pneumonia, and lung carcinoma, to ILD, IPF, and COPD. Highly sensitive to airborne infections and injury. Respiratory diseases, one of the leading causes to death and disability, makes the role of respiratory clinicians vital in every country. To heal disease conditions, to improve our way of living. Encompassing several pathobiologically distinct conditions, interstitial lung disease, ILD, demand our very attention. With 13 cases per million females and 20 cases per million males estimated, posing substantial challenges to the practicing respiratory clinicians. Despite the latest drugs and diagnostic modalities, listening to the fatalistic views about ILDs and its early diagnosis, it's time to add perspective to the way we look at the therapy through an online series. A first-of-its-kind healthcare initiative by Cipla that starts a dialogue of idiopathic pulmonary fibrosis, IPF, a discrete clinico-pathologic entity. IPF remains prevalent in 67.2 cases per million females and 80.9 cases per million in totality. Designed to sharpen skills significantly, these vital episodes shed light on medical insights, diving deep into the diagnosis and treatment for the patients with ILD and IPF. We welcome you to Healthcare Superstars, a medical show which unites medical experts from the world over, unlocks unique opportunities to share knowledge and expertise, unveils the agents of change in respiratory medicine.
Hello everyone. It gives me great joy and privilege to extend a warm welcome to everyone present here for the first edition of Healthcare Superstars. I'm Sujit Rajan, a respiratory physician practicing out of Mumbai with a special interest in diffuse lung disease, airway disease, and I enjoy teaching and I enjoy especially improving communication skills among physicians with their patients. This edition, particularly of the Healthcare Superstars, is in collaboration with the Sri Lanka Society of Pulmonology, the Myanmar Thoracic Society, AAA and AOSR from Algeria, APPM and AFMAPAT from Morocco, ASO-Pneumocito and ACME from Colombia, the Iranian Society of Pulmonology, and even the SDNCT and Pneumonaut from the Dominican Republic. Healthcare Superstars is a unique knowledge-sharing series intended to showcase world-class doctors deliberating and teaching unique respiratory issues and sharing their real-life experiences which will enrich your practices. Now, let me take this opportunity to invite and introduce our esteemed guests for this session and our key opinion leaders for today. First, Luca Richeldi. And Luca is a dear friend, professor of respiratory medicine and president of the Italian Respiratory Society. Luca is also the chair of the International Committee of the Pulmonary Fibrosis Foundation. He is the panel in charge of the production of the International Guidelines on Diagnosis and Management of IPF and the consensus classification of the IIPs. He is also the study coordinator and principal investigator of over 25 clinical trials currently ongoing at his center. He's the associate editor of the ERJ and a member of the editorial board of the AJR-CCM, published more than 300 peer-reviewed papers, and has written 18 chapters in different scientific books. So welcome, Luca, this evening. Also with us, I'm delighted to introduce Dr. Simon Walsh. And Simon, I met at a respiratory meeting a year ago for the first time. I was so impressed. Simon is an NIHR clinical scientist, National Heart and Lung Institute, Imperial College UK, and is also an honorary consultant thoracic radiologist at the Royal Brompton and Harefield Foundation Trust in London in UK. Simon as well, just like Luca, is an associate editor of the ERJ and an editorial board member for Chest and Lancet Digital Health. Simon is a member of the Scientific Committee for ATS-ERS evidence-based guidelines for the diagnosis and management of IPF, and is the academic radiology lead for the Australian and Empire IPF registries. He has over 90 original research publications on IPF staging. So Luca, tell me something that would interest our audience. What made you take up interstitial lung disease as a subspecialty?
Yeah, Sujit, that's a very good question. I actually I started with a very rare interstitial lung disease, and then when I started that, it was a little bit by chance. I was interested in granulomatous disorder, starting with TB and sarcoid, and then I jumped into a research on chronic beryllium disease, which is still a very rare disease, but very interesting. And then from there, I became very interested in the potential for curing these patients, actually, when you know the disease. Of course, in the idiopathic forms, that much more difficult, but I think we have shown in the last few decades that we may do something for these patients.
Thank you. That gives us tremendous insight into why you took up diffuse lung disease, and I'm sure a lot of respiratory physicians listening in will take back some cues from that. Thank you so much, Luca, for answering that question. And over to you for case number 1. We're looking forward to this. Thank you.
Thank you, Sujit. So this is my first case. I will share my screen with you. I hope that you and Simon will be able to see. This is a 70-year-old male, and we know that in interstitial lung disease, age and gender already tell you a lot. This is I would say, a case that is prototypical of what we are seeing more and more, which is the incidental findings. In fact, this gentleman was evaluated for surgical intervention of hernioplasty in our hospital. And as you know, before surgery, usually surgeons, they recommend a chest X-ray. When the surgeon saw the chest X-ray report, he was referred to our outpatient clinic. And on further inquiry, we discovered that this patient had a history of chronic cough, moderate dyspnea, and reduced exercise tolerance that was not reported before. Also, he was a current smoker with the high PAC years, no respiratory disease in the family, medical history basically irrelevant, no exposure reported, no particular medication taken, no recreational drugs, no allergies. When we have been listening to the chest of this patient, it was very clear that this patient had something that was not right. Velcro-like crackles were present bilaterally at the basis of the lung, and digital clubbing was present. Now, if we look at the very recent review on interstitial lung disease, in particular IPF, in the New England Journal of Medicine, we know that these two physical examination tests are very sensitive for the presence of interstitial lung disease. Also present a runny nose phenomenon, no skin thickening, no rash of the skin, no joint deformities or synovitis. Then we took a lung function test, and the lung function test clearly showed that this patient has a preserved forced vital capacity, 96% predicted. TFNO index was within the normal range, basically, with a moderate reduction in diffusion capacity. The 6-minute walking test showed a relative decline in the meters walked by the patient with a relatively well-preserved nadir saturation. Arterial blood gas showed the limit borderline for respiratory failure. Hypoxemia was present at rest. And this is the chest X-ray that was taken at the time of hospital admission for hernioplasty. And I don't know if Simon wants to comment on this, because I think that chest X-ray currently is the major challenge in identifying interstitial lung disease. Simon?
Sure. Yeah, that is the issue. I think a fact that people don't think about very often is that about 50% of patients with interstitial lung disease have an apparently normal chest X-ray at presentation. So the message from that is that chest X-ray as a screening tool for ILD is really a non-runner. What I find interesting about this particular case is that it appears that the patient was referred for a respiratory workup following this chest radiograph. And yet the chest radiograph, taking into account the patient's age, there is some, you could argue that perhaps there's some volume loss in the lower lobes, but really it's minor stuff. There is possibly some interstitial lung, increased interstitial lung markings in the lower lobes as well, but I'm actually doubtful of that. So I would say that I am impressed that the patient was referred for a workup following this chest X-ray.
So here, Luca, I'd just like to ask you, after Simon has commented on this X-ray, slightly abnormal chest film, normal spirometry. We got physicians from 26 countries here, all do not have access to advanced pulmonary function tests. How often do you see normal spirometry in interstitial lung disease, and what's a message you'd like to give out there?
Sujit, it depends very much what you mean with normal spirometry, because we know that this patient was a heavy smoker.
Right.
And we know that when you combine pulmonary fibrosis with pulmonary emphysema, now you have artificially normal lung volumes, because on one side, the patient has an obstructive disease, and on the other side, there is a restrictive disease. So very often, I think the TFNO index will look normal and the forced vital capacity will look normal. But then when you start looking at exercise tolerance, the LCO in these patients, then you start finding in these patients they are not normal. So I think it's a likely case, but I remember inquiring with this patient. Clearly, this patient had an exertional dyspnea that was considered to be dependent from the smoking attitude.
So what you're saying is normal spirometry can often be present in diffuse lung disease, but you've got to put it in the context of the clinical examination. You've got to look for abnormal signs to proceed on further investigation. Luca, please carry on. This is getting quite interesting.
Laboratory testing, because clearly something was wrong in this patient, and this is what we usually do. We check for autoimmunity. Even if I have to tell you, Sujit, that a 70-year-old male, the likelihood of the presence of a connective tissue disease, in my experience, is very low. But nonetheless, this is to exclude a connective tissue disease.
Sure.
And then we go to the CT scan, and I think I will leave here to the maestro, Simon.
Yeah, and just Luca, based on your last slide, would that be the bare minimum on an autoimmune workup that you would do for such a patient, or anything else that you would do?
I think the bare minimum we would do,
yes,
considering that the clinical suspicion is extremely low. So no physical signs, no skin reaction, nothing reported on joint pain. And also, again, the demographics that tell you this is a 70-year-old male. So I think that will be enough to exclude a connective tissue disease. I would say more than enough.
Super. Now that, Luca, you've projected the CT images, Simon, would you like to comment on this imaging?
So we really need to have a look at the whole scan so we get a full picture of what we're looking at here. But before we go to the lung bases, where I think you'll be hoping all the action is, you can see that this patient does have paraseptal emphysema. So in the upper lobes, if we look at this, for example, the easiest images are the lower two images in these 4 images. You can see there's subpleural paraseptal emphysema. And you can also see that there is emphysema within the right lung running along the mediastinum. So that's to be expected. there is also some subtle central lobular emphysema within the lung parenchyma. However, the slight issue that I would have is that paraseptal emphysema is usually incredibly thin-walled. In fact, even usually the walls are almost imperceptible. And in this case, it almost looks like the paraseptal emphysema, particularly in the bottom right image, in the right upper lobe, the anterior segment of the right upper lobe, there is an obvious wall. And I would say that it looks a little bit thicker than I would expect. Now, let's look at the next slide. Now, we've gone down into the mid-zones, and you can see that there is emerging subpleural reticulation. It's not only posteriorly at the level of the apical segments of both lower lobes, but you can also see in the bottom left image, there's subpleural reticulation within, that's probably the superior lingular segment of the left upper lobe. And there are areas of subpleural reticulation elsewhere. Now, knowing the clinical history, obviously we are concerned about an interstitial lung abnormality, that the patient has interstitial lung disease. So now we're really looking for evidence of fibrosis within these areas of subpleural reticulation, because reticulation on its own does not necessarily mean that there is fibrosis. And there's clearly no honeycombing here, but you would wonder whether there's some trivial traction bronchiectasis. Now, I'm not saying that there is, but if you look in the top right-hand image, within the apical segment of the right lower lobe, there's a sense of some very poorly defined cystic change. Now, whether this represents traction bronchiectasis within the reticulation, or it represents the combination of paraseptal emphysema and an interstitial lung abnormality, is not clear. And that's what I think we were seeing in the upper lobes. The slightly thickened septae within the paraseptal emphysema raised the possibility in my mind that there was coexistent paraseptal emphysema and some interstitial lung abnormality. Next slide, Luca. Yeah. All right, so now the subpleural reticulation almost appears a little bit more intense. And you can see that it's extending out of the dependent portions of the lung. So this is not a dependent phenomenon. This is a genuine abnormality. It's interstitial. And interpreting this CT, if we think about the way the guidelines recommend we classify this disease, really what we're looking at is either a pattern that is indeterminate for UIP, or if you believe that there is traction bronchiectasis within the reticulation, it falls into probable UIP. Now, I know that this particular case is going to be contentious. I know from a lot of research that if you showed this case to 100 thoracic radiologists, you probably find that 50 would call it indeterminate and 50 would call it probable UIP. But I think I've said all I'm going to say about it right now, and I'll let Luca proceed with the next slide.
So we had an MDT meeting with our own chest radiologist, which is not as good as Simon, but has been trained in Simon's radiology suite, so it's very similar in the interpretation. And clearly, he was unable to call it UIP pattern, even probable, so was indeterminate. So we have no known factor causative of this pulmonary fibrosis. So this was an incidental finding. And now Simon clearly showed what is the issue here. Are we talking about incidental finding, which is not progressing, ILD possibly, or are we talking about a disease? Now we had this discussion with the patient. And I have to tell you that the patient was an extremely fit and active man. As such, we decided together with him to go for the, I would say, the gold standard for dissecting the diagnosis, which, as you know, is a surgical lung biopsy by video-assisted thoracoscopy.
Yes.
We are talking here about early disease, well-preserved lung function, no comorbidities, as such, very low risk from surgical intervention.
I notice you use this term ILA. How significant is this term ILA? Because it's a new term, relatively new term for respiratory physicians. Is it something we should label our patients with more often, or are we sailing on complete uncharted territory, Luca? I think that's something we'd like to know.
ILA is referred to a condition which is by definition incidental.
Okay.
Is an incidental finding, as in this case. So there is a Fleischner document published on this. There will be more document. I think there is no agreement at all on what it is ILA, even on the name. Interstitial lung abnormality. I really do not like the term abnormality. What is abnormal? What is normal? Difficult to say. I think it's just flagging up the fact that we are seeing more and more patients that can have an abnormal CT scan without necessarily being comprised into the categories that we know of UIP, probable UIP. So I think it's something that we will see more and more when the radiology will report it. Again, I want to highlight the fact that this is reported by the radiologist.
Okay, but Luca, just hold on here. Before you report the pathology, Simon, would you report or sign off on this CT as ILA?
Okay, so this is where things are going to hot up a little bit because there's controversy all over the place. So let me say that you could argue that this is not an incidental finding, because why did we do the CT?
Right.
We did the CT because we suspected interstitial lung disease based on the clinical findings. But I think I would go through the CT with a fine-tooth comb, and I would try and reassure myself that there was nothing on the CT that made me certain that there was fibrosis. And really what I'm talking about there is I would be looking at the reticulation and I would be trying to make sure I was certain there was no traction bronchiectasis. And I think that I wouldn't be able to get that reassurance. I suspect I would find evidence of very subtle abnormalities of the airways. And that changes the complexion of the imaging completely, because now you're thinking, well, actually, technically, this falls into a probable UIP category. But clearly you can see there's uncertainty, and that by definition means that it's a case that requires MDT characterization.
Okay, thanks, Simon. Those were some excellent messages on ILA that we have. And Luca, sorry for keeping you on hold here on the pathology. And we will hand over to you to discuss the pathology slides now. But before that, any secrets on Simon that we don't know about?
So, Simon is not British and I'm not a pathologist. So, I've been discussing this with my pathologist.
This is great. Anyway, we are now rolling in free space. So super.
Pathology, when ILD pathology is easy, it's very easy. When it's difficult, it's very difficult. Now, this is the low power, low magnification hematoxylin eosin of the video assisted thoracoscopy. You see the pleural space on the bottom, and you clearly see there is normal lung, and at the same time there is very abnormal lung, and this abnormal lung is very pink. That's all I know about the UIP pattern. You get normal lung, abnormal lung, and everything looks pink and not blue. And the abnormal lung is subpleural, is in the periphery. So when you go to high magnification again, you start seeing that there is a lot of fibrosis under the pleura, and the rest of the lung is more or less normal, even if there is an increase in the interstitial space. Again, Sujit, I think it's important to put these images in combination with the symptoms and the lung function test.
Right.
So that we can explain a lot about that. And again, there are areas where there is Micro-honeycombing, clearly, that would be my interpretation of this. I always ask pathologists and radiologists is if microscopic honeycombing will become radiologic honeycombing. That would make sense a lot to me, but I don't know if Simon will agree with that. And again, fibroblastic foci. So fibroblastic foci, they complete the diagnostic criteria for the UIP pattern. Again, you see at higher magnification that these fibroblastic foci are on the edge of the alveolar spaces, clearly showing that there is a fibrotic ongoing fibrogenesis in this line. So the pathologist was clear cut, no question. We can think about ILA, ILD more or less, but when you take a surgical lung biopsy in that patient, that's becoming a UIP pattern. No question, no alternative diagnosis. In this setting, the clinical diagnosis will become idiopathic pulmonary fibrosis. You start discussing with the patient has very little symptom, but you can explain what is expected for him to happen in the future. And he decided to start with nintedanib, 150 milligram twice a day, and he's on ongoing follow-up.
Fantastic. So that's shut, locked, and sealed. This case, beautiful. Simon, a question to you. How often in the UK would you all proceed to a VATS lung biopsy in such a patient? Keeping in mind that this man came in for a hernioplasty and he's landed up getting a VATS lung biopsy and much more. So it's quite a deal for this gentleman. Your thought?
Yeah, we're doing biopsy less and less now. Right. I would say maybe 5 years ago, we were doing less than 10%. I would say now it might be less than 7%, maybe even a little bit lower. I think one of the things that we have is slightly more less restrictive guidelines with regard to IPF diagnosis. I think clinicians, their hands are not tied as much with, for example, the Fleischner white paper on IPF diagnosis, which pretty much allows the physician to diagnose IPF, make a diagnosis of IPF, regardless of what the radiology shows, if he feels from a clinical standpoint it is IPF, which is that's a big move away from the old 2011 ATS guidelines, where the only imaging pattern that gave you a diagnosis of IPF without a lung biopsy was a classic UIP pattern. In other words, you had to meet classic UIP before you could be given a diagnosis of IPF without a lung biopsy. Sure. And I think this shift toward weighting the clinician's clinical judgment on the case is really important. Sure. Because it means that it's no longer a pattern recognition exercise for a radiologist and a pathologist. It's not a conveyor belt situation where a patient comes in and they have to meet strict imaging criteria to get a diagnosis, or they need to have a lung biopsy and that has to meet strict biopsy criteria to get a diagnosis. Now the clinician can weigh in and say, the data isn't all pointing in the same direction, but I believe that this patient on strong clinical grounds has IPF, therefore that is the diagnosis and I can treat. And that's great for patients because it means that patients get access to drugs.
That was a fascinating case, and we will discuss the management of this case in more detail with Luca in the next episode. So over to you, Luca, for the second case. Please go ahead. The stage is yours.
Thank you, Sujit. We will discuss now the second case, which is somehow different from the first one, of course. Now we are discussing here a 67 years old female, again female of a certain age. This lady presents with symptoms, and she reported dyspnea on exercise by about 2 years, now deteriorating. No joint pain, no xerophthalmia, no other respiratory events before, never smokers, exposed to the passive smoking of the husband, no exposure reported. She's a housewife, brother with lung cancer, smoking, medical history, Hashimoto thyroiditis, hypercholesterolemia, extrasystolic disease. She had some cancer therapy in the past, and she didn't have any cancer therapy. She had a cardiovascular medication, propafenone, was an acetylcysteine and levothyroxine because of Hashimoto thyroiditis. No allergies reported at this time. Physical examination, there are crackles at bases bilaterally. Again, inspiratory rhonchi, no radial phenomenon, no clubbing, no skin thickening, no rash, no joint deformities, no synovitis. Because of dyspnea, we take a lung function test. Lung function test is basically normal, but there is a reduction in TLCO of 60% with normal volumes and normal flows. The 6-minute walking test is more or less normal. And here we start with the CT scan. I will now stop.
Luca, sorry, just to go back to that lung function. Again, we have a normal lung function. Yes, but with a little reduced DLCO. So this is an important question for our audience tuned in. Not everyone in the 26 countries logged in have easy access to DLCO testing. So how important do you think in the scheme of things is it to have access to DLCO? Because there are many physicians who will say, look, we got a vital capacity, we have a CT scan, we'll do a 6-minute walk test. How important is access to DLCO in interstitial lung disease practice?
I think it's important, probably is not essential.
Okay.
But I think the major role of TLCO, of diffusion capacity, is highlighting a potential interstitial lung disease or a potential problem in patient with normal spirometry. So again, being discharged as normal with a normal spirometry would be very, very easy. And in particular, I would be afraid of a patient with a normal spirometry taking a chest X-ray. Maybe the chest X-ray is also reported as normal, and then the diagnostic procedure will stop there. Again, we think we need to be conscious of the fact that given the current therapeutic situation, the cases where we can do better for the patient are cases with early disease,
sure,
not cases with advanced disease. We started maybe stopping treating patients with very advanced disease. So again, and the early disease will be a combination of preserved lung volumes and reduced diffusion capacity.
Thanks, Luca. That really gives us a great head start into this case. And before you describe the CT radiology, Simon, one question that's really a burning question for me. Thoracic or CT radiology of the lung. What really makes this branch? We have just a handful of CT radiologists in our country who are really interested in lung CT radiology, and we know, as I'm sure you know, that there's a huge difference between a poor quality scan and a good quality scan. And also there's a massive difference between a report which is done averagely and which is reported really well. So what enthused you as a CT radiologist to get interested in this branch?
Yeah, well, I think the problem is that, and I think that this may also be true in pathology, that radiologists, chest radiologists, probably spend, in Europe at least, spend most of their time looking at lung cancer and looking at nodules and maybe looking at lung infections, and that would probably make up the bulk of their work. I suspect in Asia, lung infections may take up a bigger amount of their work, but certainly interstitial lung disease for most chest radiologists is only a small part of their work. And it's one of these things that really, unless you're seeing a lot of ILD, it's very hard to get good at it. You know, there are only a few centers around the world that see an awful lot of ILD and that are good for, you know, doing specialist training in interstitial lung disease. And unless you actually get to go to one of those centers and you spend a couple of years really focused in on interstitial lung disease, I think it's very hard to get a grip on the interpretation. There's more to it than just reading a book and then trying to apply what you see in books. The field is moving so fast, and the thinking about it and how we classify it and what patterns are important and this sort of thing, and how we quantify disease progression, all of this stuff it's moving so fast that actually most textbooks are several years behind. Even books that are being published now, the quoted literature in them is maybe a year or 18 months behind. So it's not an easy thing to get to grips with unless you go somewhere where you're surrounded by people who are focused on ILD, and you get to see a lot of ILD imaging. You do the interstitial, the ILD MDM works best when everybody is, I don't want to say thinking along the same lines, because debate and disagreement is part of MDM discussion, and that's important, but everybody is kind of on the same page, that they understand how each other thinks and what are the important things to know. What does Luca need to know from his radiologist about a particular case? Yeah, so this is a difficult case, and Luca gave me, he didn't just send me the imaging, he sent me probably the imaging life story of the patient. I selected some specific images just to highlight what I think are the salient points. So this is a slice taken sort of mid-tracheal level, and you can see that there is definitely an interstitial lung disease. It's very limited in extent. You can see in the anterior segment of the left upper lobe, there's subpleural reticulation. There may be some traction bronchiectasis within here. The reticulation also you can also see it in the anterior segment of the right upper lobe. And there are just little areas of sort of pleural scruffiness that I think are early area interstitial abnormalities elsewhere. Now, there are a couple of subtle added value features here, and that's that at least here in the anterior segment of the right upper lobe, there's an impression of some very subtle mosaic attenuation. In other words, this area here looks like it's a little bit low density. Maybe this area here, which you may think reflects very mild airways disease, and in airways disease in conjunction with fibrosis should at least raise the possibility that the patient has chronic hypersensitivity pneumonitis. Now, there are a couple of things that I thought of when I saw this CT before I even looked at the case, and what is interesting is that here's the left oblique fissure, that we're just seeing the top of the apical segment of the left lower lobe. It looks a little bit nodular. There's some nodular interlobular septal thickening up here as well. Now, you get that with granuloma deposition in particularly in patients with sarcoidosis. Now, to be fair, that's the only thing on this image that would even raise that in my head. This peripheral distribution of the fibrosis is not a sarcoid thing, although of course sarcoid can do anything. As we scrolled, this is an image just at the level of the carina. This is just showing that there's definitely fibrosis. This is an abnormally distracted airway, an area of traction bronchiectasis. Again, you see subpleural reticulation elsewhere. And then it's sort of more conspicuous at the lung bases. Just for your own knowledge, there's an osteophyte here, and occasionally patients get reticulation here within the medial basal segment of the right lower lobe. And it's a consequence, it's a mechanical phenomenon due to osteophytosis. It's not a frank interstitial lung disease, but of course here we have an interstitial lung abnormality extending all the way around in the posterior basal segments. Well, we're almost in the posterior basal segments. So this is a peripheral, very limited fibrosing lung disease with the possibility of some airways disease combined, raising the possibility of hypersensitivity pneumonitis. And then there's that caveat about interlobular septal thickening and fissural or interlobular septal nodularity and oblique fissure nodularity, which just raises the sort of shadow of sarcoidosis. Now, I know that sarcoidosis and chronic HP are both granulomatous diseases, so sometimes this is a diagnostic dilemma occasionally, not a very common one. Usually we're trying to separate UIP from chronic HP. But Luca was kind enough to give me some multiplanar reformats, and we have coronals here, and I think you'll agree that there are definitely density changes here in the lung, in the left upper lobe, reflecting airways disease, and then the fissural nodularity here. And actually I think let me go back one, this sort of nodularity along here, along the fissures, not so conspicuous there. You have to be careful on the fissures because you get vessels that travel up through the fissures and they can give you false kind of nodularity. And I think that some of the interlobular septal thickening here posteriorly on these coronal images is a bit nodular. And then I'm not going to show you all of these, but I think Luca has provided very nice sagittal images. Here's the fissure and it looks nodular. And here's another image, the oblique fissure. There's nodularity up here. Now, my strong feeling is that this is chronic HP, but I just raise that caveat.
Okay, quick question here. There are a lot of images that you have shown, Simon, and I can tell you that in many countries, film is still often the norm, and soft copy imaging is not easily available or accessible. So you've shown us coronal, sagittal images. Thanks to Luca, we have all kinds of views available. How important, Simon, are seeing the CT from all these perspectives important in understanding the lung picture better?
That your question regarding these extra images extends to the need for expiratory images, which Luca has provided us as well. And the purpose of expiratory images is to accentuate airways disease by showing us more conspicuous areas of lung density heterogeneity. And you can see there's obvious air trapping in these lungs. Now, I'm often asked, do you need to do expiratory images with all patients with suspected ILD? The most recent ATS chronic hypersensitivity pneumonitis guideline recommends expiratory imaging with all new cases of suspected ILD. Now that's on the record, I would say. Off the record, I would say that expiratory imaging, for me in my practice, only tends to be helpful when I'm a little bit uncertain about airways disease, and I want to accentuate it. I want someone to highlight it. I want the protocol to highlight it. So for example, in the very first image, I perceive some heterogeneity in the lung parenchyma here that I think may be related to air trapping. And in this case, I think that, expiratory images are quite useful because they basically confirm what I suspected. There's obvious density differences.
Thanks, Simon. That was fantastic. Luca, back to you. What did you do from here?
Okay, so what to do when you have that type of diagnostic dilemma?
Yes.
And then, as you may imagine, we decided to get some more information. And one of the information that pulmonologists looked for, in particular when, as Simon pointed out, there is a differential diagnosis between granulomatous diseases, is the bronchoalveolar lavage. Now, I don't know how much bronchoalveolar lavage really had. However, it's a very common procedure, it's safe, it's relatively inexpensive, and these are the results for these ladies. There is an alveolitis, 320,000 cells, 23% lymphocytes. Again, I would like to remind the people that in a normal bronchoalveolar lavage, more than 95% of the population will be represented by macrophages. So we have an increase in lymphocytes, and the lymphocytes had the CD4-CD8 ratio above 7. So there's such CD4 T cells are basically the majority of these lymphocytes, that there are no mycobacteria. So just to remind you that this lymphocyte with CD4 CD8 T cells ratio is something that we use in clinical practice to support the diagnosis of sarcoid, but it's based on very little data. a small study, samples. The original study from Costabel group was a handful of patients. But again, something that we use in clinical practice. And in fact, the other laboratory tests showed very low CRP, within normal ACE, normal IgE, normal calcium, normal vitamin D, and negative autoimmunity. Now,
so Luca, just to ask you here, your transbronchial biopsy I noticed was non-diagnostic, and we did a little survey among our respiratory physicians also in our country, and we realized that 50% of them would probably proceed in such a case to a transbronchial biopsy and also land up with an inconclusive diagnosis. So transbronchial biopsy we know is often non-diagnostic in an idiopathic interstitial pneumonia. So BAL is probably something midway between the transbronchial biopsy and doing nothing. So when should we do a BAL? When should we proceed to doing a transbronchial biopsy, or just not do anything? Your comments here.
My take is that BAL provides some important information. Transbronchial biopsy is very variable. How many biopsy, how large, how good is the pathologist that is looking at the transbronchial biopsies? Sure. And again, in this case, transbronchial biopsy at our institution were non-diagnostic, were non-conclusive. So we took both bronchoalveolar lavage and transbronchial biopsies. Right. And so my take is that, yes, you can have some supporting information from bronchoalveolar lavage. It's very rare to have a conclusive diagnostic information.
Sure. I think that. And then what happened? What happened next? That's the question.
It was the same as Simon, more or less. It was a fibrotic form of sarcoid. Findings from the BL were supported. We have a lymphocytosis with an increase in CD4 T cells, no exposures supporting a chronic HP. TPP was non-diagnostic, so we decided to start steroids. And this is the dose that we have in our institution for sarcoid, which is 1 milligram per kilogram daily, with a gradual tapering to 15 milligram daily. That is where we check for the effect of the therapy, basically with a second high resolution CT scan. Simon, I think, will be able to comment on that. And that was 8 months later.
Okay, so that was a fair dose, and you're looking at 8 months interval between those two scans. So Luca, you gave a fairly high dose, 1 mg per kg, adequate time. We had 8 months, so we would sometimes even give probably 0.5 milligram per kg in such cases. But I think you gave enough steroid and you've got enough time between those scans. So Simon, adequate steroid, adequate time. Tell us about the fresh CT scans.
Okay, so what we have are the images at the diagnosis on the left and 8 months later. And actually at this level in the upper lobes, there's not a huge difference. You've got to take into account that actually the protocol is slightly different. On the right, we're using a harder high resolution CP algorithm. On the left, the images look slightly softer. And that's making the images on the right look a little bit more, shall we say, reticular. I think there is evidence of progression. What's interesting to say, I think, is that one of the earliest signs of hypersensitivity pneumonitis becoming fibrotic. Now, this patient obviously has fibrosis on their CT, but one of the earliest changes is you get interlobular septal thickening in the upper lobes. That's not to say that you get nodular thickening that we discussed earlier, but there is interlobular septal thickening in the upper lobes, actually at both time points, perhaps a little bit more 8 months later. As we go down, though, the changes become much more obvious. So there is evidence of progression of the reticular abnormalities peripherally. There is inhomogeneity of the lung parenchyma. There's slightly low density lung here, probably normal density lung parenchyma here. And the further we go down, the more obvious the progression becomes. So I'm scrolling right down into the lower lobes now, and you can see that there's quite significant progression peripherally of the reticulation. There's areas of traction bronchiectasis that weren't present at all on the previous scan. And there is some subtle lung inhomogeneity as well. There's some areas of low density, for example, up here. This is airways disease. Keep in mind that patients with sarcoid can have endobronchial sarcoid, which can cause airways disease as well. So, but for me, the front runner here is chronic hypersensitivity pneumonitis.
Okay, before I know, I'm aware, Luca, that you moved to another MDT once this imaging was available. But to understand this better, especially for young respiratory physicians tuned in, how practical is online MDT? Because you have MDT so often in your center. Would online MDTs be practical, considering that we don't always have CT radiologists like Simon?
So, if all you can have is a virtual MDT, that's fine, that's fantastic. But if you can choose between the virtual and the face-to-face MDT, I think I don't know of any study, formal study assessing that. But my feeling would be that the face-to-face MDT will be more effective.
Now that you had your MDT going, do tell us what came out of it.
So we've seen the progression basically in high resolution CT scan after 8 months of, I would say, a relatively high dose of corticosteroid. This is something that I would like to highlight. When I use corticosteroids, I tend to use them full dose because you never know if this is an effect of low dose. Clinical deterioration, radiological deterioration, functional deterioration. Again, now the FVC is down, TLC is down, the LCO is down, desaturation during working test is down. So everything is going in the same direction. The three domain: symptoms, imaging, and lung function.
Right.
So there was a significant clinical and radiological worsening. At that time, again, we decided to go for a surgical lung biopsy. Middle lobe and right upper lobe. You can discuss here the need for a surgical lung biopsy, but again, it was due to the fact 67 years old female lady without a diagnosis, already tried corticosteroids, what to do? And here are the results. So again, if you go to my basic use of lung pathology, we start seeing here is a high magnification, but there is more blue than pink. And there is no normal tissue here. When you look at lower magnification, yes, there is some normal tissue, but the interstitial area is still full of blue balls, which is lymphocyte T cell, is what we get from the bronchial lavage probably. And now you start seeing that there are disruption of the lung architecture. There is basically no normal lung here, but there are aggregates of T cells, aggregates of lymphocytes. They look like granulomatous disorder, granulomatous cells. So we have granuloma, we have normal tissue, is more blue than pink, but at the end of the day, the pathology report is inconclusive. Again, we have clearly a granulomatous fibrotic disorder. That's fine. And the granuloma are, they look like sarcoidosis, but we don't know if they are really sarcoidosis, if they are chronic HP, there are sarcoid, there is fibrosis, and there is some honeycomb. So the disease is progressing. So what do we do now? I would say that in this instance, the tissue added very little to the report of the radiologist because we had no real clue and we didn't have a UIP pattern, even if Simon pointed out to the fact that the distribution now of the disease is maybe more important than the single, what we see in the single biopsy. So these are the open questions.
Fantastic, Luca. I think that's closed this case beautifully, diagnosis of chronic HP. And we are going to have a very interesting discussion on the intricate aspects of the management of this case in the next episode. So we're looking forward to that. So we have questions from over 20 countries coming in, and so I only have time to put a few across to you. But the first question I have is from the beautiful country of Colombia. And this question asks you, Luca.
If a radiologist reports probable or possible UEP in patient with more than 60 years old, how sure can we be this is IPF? We don't proceed a surgical biopsy?
So first, I think, based on the current guidelines, the possible UIP pattern should not be reported. That should be a probable UIP pattern. First, I think we depend from the clinical context. Again, if we look at the documents from ATS or from the Flying Society, the clinical context is very important. The presence of additional signs, the presence of exposures, the presence of laboratory tests suggesting connective tissue disease. I think in the absence of all of that, and with that age, and when we exclude all the known cause of pulmonary fibrosis, I think the diagnosis of IPF is quite likely and quite reasonable.
All right, now we have the next question from Nepal.
Namaste everyone, I am Dr. Prajwal Shrestha from Kathmandu, Nepal. The question that I want to ask is, can we just closely follow up and observe the patient with early features of IPF by doing biannual pulmonary function test, DLCO, and HRCT test without starting them on antifibrotic therapy? To add on this, I also want to ask, is biopsy really required in a patient who has typical features, clinical radiological features of IPF? If biopsy is required, then when and what are the conditions is required in a patient?
I think if I can answer that question first, I think it's a kind of a watch and see attitude.
Right.
If we are certain enough of the diagnosis of IPF, I don't think that the watch and see attitude is reasonable, because it will be relatively similar to the watch and see lung cancer. We know that these patients will progress, different rate, different type of progression. They can have an acute exacerbation, and we know the drugs that we have available now, they reduce the rate of progression by a significant fraction. So if the diagnosis is certain enough, is confident, then I don't think that watch and see is an acceptable strategy. Is a different thing when the diagnosis is uncertain, because you cannot take a biopsy, or your radiologist is unsure, you don't have any other additional, maybe you have some exposure, so that would be a different scenario. But in the setting of a confident diagnosis, I don't think that as of today, with available drugs in your country, a watch and see attitude will be correct.
Sure, cool, terrific. So the next question coming in from Algeria to Simon. Simon, is there any specific feature on a CT scan that can conclusively rule out IPF? Is what the physician wants to know.
No.
Nothing.
Okay, so let me qualify that.
Right.
That's a really interesting question, because since 2011, if you look at the UIP criteria, the criteria for UIP pattern in the IPF guidelines, you'll see on the very far right, there's a column that gives you a list of patterns which are considered inconsistent with IPF or suggestive of an alternative diagnosis. Now, what's interesting is that the major diagnostic dilemma in IPF MDM usually is separating IPF from chronic HP, or separating it less commonly from fibrotic NSIP. Now, for a long time, it was thought that mosaic attenuation, or inhomogeneity of lung density, as we saw in the last case, was a feature that is incompatible with IPF or inconsistent with UIP. But that's not actually true, because we know this pattern reflects airways disease, and we know that patients with IPF have exposures. So your patients, they have gastroesophageal reflux is one, and potentially smoking as well. So there was a paper published last year that sought to look at this mosaic attenuation pattern, because it was being used so often to call patients CHP, chronic HP, as opposed to IPF. To really work out, is this pattern atypical for IPF or isn't it? I know in the Brompton that they put no stock into mosaic attenuation as a distinguishing feature for chronic HP. Now the problem is, and I don't want to talk too much, but mosaic attenuation can occur for a variety of different reasons. It's not just one pattern. And it actually it's a combination of several patterns together. This is worth telling you about because it's important. So mosaic attenuation is differences in the lung density, and this is one example. You have low density lung surrounded by normal lung. This is due to air trapping. You have another case here where you have normal lung surrounded by ground glass opacification. This is a patient with interstitial lung disease, and the ground glass is the infiltrate, and then there's an area of spared lung here. But there's another pattern which is a combination of the two of these. So you have areas of air trapping, areas of ground glass opacification, and areas of normal density lung. This is called the 3-density pattern. And we know from at least one solid study published in the ERJ last year that while these patterns can be seen in patients with IPF or UIP, this pattern is highly specific for chronic HP and very unusual in patients with UIP. So while it doesn't 100% rule out UIP, I mean, I think in medicine you never have any guarantees of anything. There is no such thing as always or never. But I think that you could say that this pattern is atypical for UIP and makes UIP unlikely. So what I would say to those watching this webinar, when you are looking for mosaic attenuation as a means to identify chronic HP and rule out UIP, look for this 3-density version of mosaic attenuation. And if you have any doubt, you can see, you will find the definition for this in the current chronic HP guidelines set out by the ATS.
Thank you. Fantastic. Thank you so much for bringing up those images to illustrate your point, Simon. That's very, very useful to our audience. And the next question comes from the country Iran.
Should we have a checklist for ruling out potential triggers for hypersensitivity pneumonitis when taking a history? And how exhaustive should it be in a busy respiratory practice? Thank you.
What do you say, Simon? I think it's difficult.
I mean, in some ways, you're limited by the what you have available to you at your institution. So, you know, it's kind of a how long is a piece of string question. You know, you ask the question. It's like saying, if you have all the tests available to you, how many tests will you do? Well, you'll do all the tests available to you. If you only have a limited set of tests, then. But I think I know what the person is driving at. There is a paper that's come out recently. I'm not sure whether it's. So the current ATS CHP guideline, and there's also a publication in the Annals of the ATS. It's the White Journal, which looks at CHP as well, and it gives you a list of the things that you should be testing for, and a fairly good information on, you know, the exposure history and what you should be looking for from an exposure point of view. I think from a connective tissue disease point of view, again, it depends on what you have available to you, but you know, the diagnosis of various CTDs is well documented in guidelines, so it's really a matter of just doing the right tests, I would imagine.
We have a final question here. Luca, in such a patient, would you proceed to a cryobiopsy, is what someone is asking. And what is the role of CT-guided lung biopsy? So I guess different people like to do different things. Everyone has expertise in a different area, but your views on this as an ILD physician would be much appreciated.
As such, we can do transbronchial cryobiopsy for cancer. We do that. We don't use it usually for interstitial lung disease. The reason is the following. If the patient really needs a biopsy, I think that we need to have the maximum information from that biopsy. And if the patient is at risk for a surgical lung biopsy, will be at risk also for a cryobiopsy.
Okay, that's interesting. And a CT-guided lung biopsy in someone who's probably unfit for a cryo or a VATS lung biopsy. A thought there?
It's very attractive. I've been thinking about that, but I know by discussing with Simon also that patient with potential interstitial lung disease and maybe only common traction bronchitis, there might be a very high risk of pneumothorax. And the amount of tissue that you can have will be in any case very unlikely to provide you with reliable information. So after thinking about that perspective for a study, in particular after discussing with radiologists like Simon, I think I came to the conclusion that that approach is likely not to provide an important information. One thing, Sajid, if I can, I think a very promising field is the field of molecular profiling on transbronchial biopsy. And again, I think the Envision test, which is now currently available and FDA approved, which is providing a very high likelihood of a molecular UIP pattern.
Okay.
I think that's the future. That I believe in that. I believe in a very low risk procedure and a very highly informative test. So that would be my look for the future.
Thank you. That was fantastic. I can't thank Luca, you and Simon for this fantastic assessment of the two cases we have had on this episode today. So on that note, I hope we have addressed and resolved at least some of the confusion in the evaluation of an ILD patient. That's it from our end today, and I would like to sincerely thank our collaborators for this meeting, which include the Sri Lankan College of Pulmonology, the Myanmar Thoracic Society, the Iranian Society of Pulmonology, AAA and AOSR from Algeria, AFMAPATH and APPM from Morocco, ESONIMOSITO and ACME from Colombia, and SNDCT and Pneumonorte from the Dominican Republic. I look forward to seeing you soon again for the second edition of Healthcare Superstars, where we shall be addressing a new problem related to these cases, IPF and progressive fibrosing ILD, making the difference in the management of such cases. Thank you very much, everyone, for joining. See you soon. Be safe. Stay safe.